Hello, I'm Dr. Christopher Sletten. I'm the clinical director of the pain rehabilitation program at the Mayo Clinic in Jacksonville, Florida. In 2015, we videotaped our first central sensitization video to describe the process that happens with chronic symptoms and also to explain how a program like ours can be very helpful for individuals with chronic and hard to treat symptoms. We're redoing the video at this time for a number of reasons. In the past several years, there have been a number of clinical developments that have allowed us to expand the scope of patients that we're able to help. And so pain rehabs have always been effective for individuals with migraine headaches, fibromyalgia, chronic back pain, other musculoskeletal pain disorders, chronic abdominal pain. We've really been shown to be very effective and have long-term benefit for individuals that have those issues. Today I want to introduce the concept that we are also able to help individuals with a wide variety of chronic symptoms, including those patients that have Ehlers-Danlos, POTS, functional neurologic disorders. Even post-COVID patients are benefiting from this program. And the core reason for this is that we are expanding our understanding of the concept of central sensitization, which has allowed us to broaden the reach of our clinical scope. So today I'm going to go over the model of central sensitization again, adding some pieces and hopefully amplifying on some of the things that were not covered in the first video. First, we're going to start with a brief discussion of acute and chronic medical conditions. And this is a very important distinction to understand because most of medicine, whether we're talking about conventional medicine, we're talking about alternative medicine interventions or new innovations in treating symptoms, most treatments today focus on the problem as if it were acute. And so I want to distinguish the two conditions. An acute medical problem, by definition, is time limited. The cause is generally known, onset is known, treatments work, and tissue damage and symptoms match up. An example, a broken ankle. Someone steps awkwardly off the curb, they twist their ankle, they hear a crack, they go to the emergency room, it shows a fracture. It fractures where it hurts, we put a cast on it, we're good to go after 6 weeks. Sinus infection antibiotics, hot appendix, appendectomy, those kind of things. And even some complex medical situations like cancer, some cancers, if treated in a timely fashion with proper treatment, they can be expected to resolve. So this is what we expect, this is what we desire, this is what we often get out of modern medical care. However, there are instances, and this can happen for a variety of reasons, where the syndrome or the disease or the medical condition changes to chronic and the rules change, frankly. So when it becomes chronic, it is now long-lasting, perhaps even permanent. We're not always sure of what causes it to become chronic. We aren't even sure when it becomes chronic. Treatments become very plus-minus. And tissue damage and symptoms don't match up so well anymore. This might be the person with the broken ankle that 3 years after they break their ankle, it still hurts. And the problem with this scenario is historically, persons with this problem often are doubted. Often they're told, we don't see any problem on the MRI. We don't know why you have symptoms. And in fact, historically, this has often been relegated to the realm of psychosomatic. Maybe you're depressed. Maybe this is some issue that you haven't resolved in your life. And nothing can be further from the truth. Those of you watching that have chronic symptoms, you know it's real. You know you're not imagining this. And I want to emphasize this several times today, that this is not a primarily psychological problem. However, when this happens, and we still apply an acute methodology, it just leads to more problems. And so I'm going to, over the next several minutes, elucidate the pattern of this and also some solutions. So I'm going to go over to the rough sketch, very rough sketch, admittedly rough sketch of the nervous system. It's the spinal cord in the brain, or it's supposed to be. The human nervous system can be divided generally into two parts, central and peripheral. Central nervous system is brain and spinal cord. Peripheral is generally sensory, motor, and the autonomic nervous system. We're going to focus initially on the sensory pathways. The sensory pathways begin in the body. We have sensors in every square inch of our body except for our hair and fingernails. This is also an important concept to realize because symptoms, chronic symptoms, can arise from almost every system in our body. So you can see this happens in any part of the body. So sensory processing, let's start with just a very basic elementary explanation. Sensory processing is basically supposed to work like a light switch. Stimulus present, sensation. Stimulus absent, sensation gone. And that's how most of us experience our sensory world. If I take a sip of coffee, I taste the coffee when it's on my tongue, I swallow it, the taste goes away. But for a variety of reasons, these sensory pathways can become augmented or upregulated over time. And for purposes of your understanding, I want you to think as broadly as possible. This can start with an injury. This can start with a progressive disease. This can start sometimes seemingly out of nowhere. But there always starts in the body with a change in the way that the sensors perceive and react to stimuli. Very quick explanation. If I tap on my hand with the back of this pen, I can report that every time the pen makes contact with my skin, I'm perceiving a tap. When I stop, it stops. I could, however, develop a situation called neuromodulation where I tap long enough that when I stop, I might still feel tapping for a little bit. We've all had that happen to us. If you've ever been on a boat and you get back on dry land and you still feel like you're going up and down. Or you've been on roller skates or ice skates and you take them off and you still feel like they're on your feet. Or if you're into such things, you get off the roller coaster and you're back on the ground and Shikra still has your soul up in space somewhere. That's normal. But the third iteration is where the sensors can be stimulated to such a degree that they never shut up. Or they shut up and turn on at random times. That's called neuroplasticity. That's the beginning of the change. And it gets more complex from there, because with signals that have now changed in the body, talk about them being upregulated, now the body is sending a stronger signal to the brain and the primary target of all that sensory information is what we call the sensory cortex. The sensory cortex sits in both hemispheres of the brain. It's a strip of neurons that's organized by body part. So everything that happens in our body registers up in the brain. It's a body map. So if I stub my left big toe, it registers left big toe in the brain. That's an important concept because for a very long time it was poorly understood how symptoms can move around, how they can popcorn, how they can appear here one day and there the next. I've had patients that broke this arm and over time this arm hurt. It's because they're neighbors up here. And when they get riled up, they can affect other sensory parts of the body. Secondly, as that gets sensitized, it starts to react more vigorously to less input. It's sort of like if we look at this area like a smoke detector. And a normal smoke detector in the kitchen would only go off when you burn something on the stove. But now it's been swapped out for a super duper sensitive smoke detector that goes off at 100 decibels when you light a candle in the bedroom. Is the candle still aflame? Yes. Is it dangerous? No. But the brain becomes so reactive that now there are sensory experiences that don't necessarily translate to what's going on in the body. That's confusing. That's frustrating. but that's part of the amplification in the neuroplastic response. So with this, we talk about the fact that symptoms can grow, and so we see pain, fatigue, sense of dizziness, nausea, numbness, burning, itching, tingling. All sorts of sensations can emerge from this process, as can triggers. Light, sound, smell, taste, touch, temperature. Now all of a sudden we're in a situation where symptoms seem to get worse, more things trigger the symptoms, and that's where the problem becomes more and more worrisome and more confusing. But before I move on, I want to highlight a second part of the brain that could get impacted. It's a neighboring map, a parallel map, that's called the motor cortex. It too is organized by body part. So what is supposed to happen is we are supposed to have this smooth sensory motor flow. Sensations come in, direct our motor or movement activity so that we can navigate our environment. So with the changes in the motor cortex, we see individuals that start to have issues with movement. It might be simple as a tremor or spasm or stiffness. It might be a whole body episode where it looks like they're having a seizure. And our neurologic colleagues will tell us we don't see evidence of epileptic activity in the brain. We don't see evidence of a progressive neurologic disease, but these individuals are still smitten with these chronic symptoms. So from a motor perspective, we see spasm, tremor, and these also can be triggered more easily. So let me take a pause for a second and put this in context. If all these symptoms are emerging, and as you're struggling with them, you and your providers and your family are still viewing this through an acute lens, this is a very worrisome development. Because if you have an acute problem and it's getting worse over time, something has gone terribly wrong. If I break my ankle and 3 weeks into casting it hurts worse than the day I broke it, something's gone wrong. Or if a patient's going through chemotherapy and 6 weeks into chemo they have more tumors than when they started chemo, there's a problem. But this model predicts worsening of symptoms over time unless we do something different. This model also explains why traditional treatments, whether they're conventional medicine, alternative medicine, whatever, stop working. Because you can't unsensitize sensitized sensors. You can't cut it off at the spinal cord, and you can't turn it off in the brain. And so persons with central sensitization syndrome problems begin to get frustrated. The shots don't work. The acupuncture stops being effective. The massage, the tinctures, the diets, the supplements, the pain pills, it all is doomed to fail ultimately. And this is where I want you to be very cautious with what's out there and being promised right now. The internet is full of false promises. It is full of pseudoscience. It is full of people out there saying, oh, if you just take this supplement, if you just do this diet, if you just rub this lotion, you're going to be fine. It's impossible. This can't be stopped with any somatic physical treatment. Lastly, before I move on, there's also no psychology here. This is not primarily a psychological disorder. Can psychology make it worse? Of course, it makes all of our physical things worse. But this did not start from a psychological cause. This is not a somatization disorder. This is not a conversion disorder. This is none of those things. So I want you to take courage and understand that this is not psychological either. So with all of that, I appreciate the dilemma you find yourself in. Worsening symptoms, fewer answers, treatments stop working. We can't medically treat this. We can't psychotherapize you out of this. What do? Well, here's the answer. We need to approach things differently. Because if this pathway is generally unchangeable, then we have to find a different direction. And so from a pain rehab perspective, from a symptom rehab perspective, we've arrived at 4 targets of treatment. Physical, emotional, behavioral, and chemical. I call these the reactive and maintaining factors. Reactive because these are issues that when you first started having your problems, it made sense to do certain things. If it hurts, don't do it. Put ice on it, rest, get a shot, take a pill. It's scary. So all those things make sense, but in the long term, these are the things that now make this worse. And so in our program and in our pain rehab approach, we look at physical deconditioning. No one has ever come to pain rehab in the best shape of their life. It's hard to maintain physical fitness in the face of chronic symptoms. Now, for sure, this is on a continuum. Some individuals come to us and they're just slightly deconditioned. Others are profoundly deconditioned. The level of conditioning doesn't matter. We're just going to reset the mechanism, work on whole body reconditioning, strengthening cardio and flexibility. Instead of focusing on different body parts, we're going to look at the whole body as a unit to get it stronger. We talk about our physical therapy intervention as fit for life, trying to get you back on track. Emotional. It's distressing when you can't do what you want to do when you want to do it. It's distressing when you have out of control symptoms. It's distressing when there's no answers. And some of our patients come with previous mental health issues, but a lot of our patients come with anger and depression and anxiety and stress because of the problem. But in either case, we address it through a cognitive behavior therapy model. We give a lot of tools, a lot of practical advice, a lot of application to help individuals reduce the emotional distress. Behaviorally, there's 2 issues. Pain behaviors, which are anything a person says, does, or thinks that reminds themselves or others that they're having symptoms. So we work on reducing those because those feed this. We also work on moderation because pushing and crashing stirs us up. Many of you watching this video have been busy and active folk. You're type A, you want to be in the game. And every time you felt better, you thought, I got stuff to do. And you got up and did stuff, and you overdid it, you pushed, stirred everything up, and you crashed. Pushing and crashing feeds the problem. Every push stirs up symptoms, every crash leads to deconditioning. And then finally, chemical. And we're all fully aware of the dangers of addictive drugs, and certainly that's part of our scope. We do help people come off of opioids and benzodiazepines and sleeping pills and things like that. But we're also very concerned about any number of symptom-treating chemicals that can add to the problem. Because whether the drug is psychoactive or not, anything you put in your body for your symptoms reminds yourself and others that you're having symptoms, and it can stir up the pathways. And as I mentioned a few minutes ago, there's nothing that's going to turn this off. There's no chemical. There's no natural substance. There's no vitamin. There's nothing that's going to turn this off. So all of that stuff turns out to be more fuel on the fire. So as we wrap this up, I want to make one last analogy. I often think of an acute medical problem like a house fire. When there's a house fire, it's a big deal for a localized area. Fire department comes in, puts out the fire, the family rebuilds, etc. But chronic is more like a forest fire. Forest fires have impact well beyond the boundaries of the burning stuff. If you've ever been near a forest fire, you know the skies get smoky for sometimes hundreds of miles away. It can change weather patterns. And it doesn't just go out with enough water. Unfortunately, we've all seen far too many newsreels of forest fires consuming hundreds, if not thousands of acres of land. And the only way to get rid of a forest fire is you contain it. You cut off the burning stuff from the non-burning stuff. So those brave men and women are out digging dirt berms and lighting backfires and doing whatever they can to contain the fire. Well, very much the same way with pain rehab, we're working to cut the fuel off the fire. That's why we work on these 4 areas. So by introducing physical conditioning and fit for life, by reducing emotional distress, by normalizing behaviors, by getting people off of chemicals, we're cutting the fuel off the fire. And when we see that, we see the symptoms begin to become contained, the impact dies down, and the person's functioning improves. And so over time, the 3 weeks of the program, but also well beyond the program, we see this new pattern emerge where the focus is on functioning, not trying to eliminate symptoms. And as we work with our patients, we teach them how to work through these problems, not try to stop them. Because at the end of the day, this isn't directly stoppable. It's not necessarily curable. It's a permanent change in the system, but the permanence doesn't have to mean permanent impact. It just means that the system has been revved up, but we can teach techniques to help it calm down, to reduce the impact, to improve the quality of life. So if you have chronic symptoms and you've struggled with getting them treated effectively, if the quality of your life has declined, you're struggling with sleep and mood issues and decline in occupational and daily functioning, relationship changes, that's the stuff we can help with. And I just want to, again, urge caution about pursuing the quick fixes. There is no quick fix. This is hard work. It takes time. I just want you to understand this, and I want you to see the breadth of what we can help with. So again, to repeat my opening statement, not only fibromyalgia, migraine headaches, back pain, musculoskeletal disorders, abdominal pain, but also individuals with Ehlers-Danlos, POTS, functional neurologic disorders, post-COVID syndrome, and other things can benefit from this approach. Thank you.